Okay, so we are presenting you in this PowerPoint one of the Healthy People 2030 objectives, HDS 0.4, and it's reducing high blood pressure in adults. And this is a nursing approach using the S-bar. So in this presentation, we have these objectives we're trying to cover. So our first objective is identify current trends and contributing factors to adult hypertension in the United States. Our second objective is evaluate evidence-based nursing interventions that support blood pressure reduction. Our third one is apply professional nursing rules in patient education and community-based hypertension management.
So the situation, again, our objective is to reduce the proportion of adults with high blood pressure. Blood pressure diagnosis and control has been an issue in the US for years. Some facts, blood pressure is the pressure that occurs when blood pushes against the walls of your arteries. Blood pressure elevation was defined as a systolic blood pressure of greater than or equal to 140 millimeters of mercury, or diastolic blood pressure greater than or equal to 90 millimeters of mercury. Hypertension is the leading risk factor for stroke, cardiovascular, and renal disease. Current statistics, about half of US adults have hypertension. Only about a quarter of those adults have their blood pressure under control. In 2023, high blood pressure was a primary or contributing cause of about 700,000 deaths in the United States. There has been little to no detectable change in the past decade. On the left-hand side, I have two charts. The top one is prevalence of hypertension among adults aged 18 and over in the years two, 2015 to 2016. And then the bottom one, I have the prevalence of hypertension from August 2021 to August 23rd, 2023. So the top one shows, if you look at the total amount of people on the left-hand side, it shows about 63% of people 60 and over have hypertension. And the bottom one shows how much it's increased to 70, about 71%. So the prevalence has increased over time. So my thought was, wouldn't the objective be declining if prevalence is increasing? But the answer is no, because prevalence goes along with incidence and duration of the illness. Health-based manufacturing and treatment options have increased over the last several years. Therefore, more people are living longer with the disease. This increase in the prevalence rate doesn't necessarily mean that the objective is declining. We're at a standstill. We're neither improving nor worsening. And this last chart on the right just shows awareness, treatment, and control, the percentage of people that are aware, percent of people that are being treated, and the percentage that are under control. And the two different, the dark blue is showing from 2017 to 2020, green is from 2021 to 2023. And they're kind of, haven't gone up or down, just kind of straight across on the board. There's also persistent disparities in minority and low income populations. Hispanic Americans have lower rate of health insurance than white Americans, precluding access to high quality primary care for diagnosing, treating, and monitoring hypertension. Significant differences in hypertension control rates among Black adults and suggested poorer rates of control among Asian and Hispanic adults when compared with white adults. Low income population, less than half of those affected receive diagnosis and treatment, largely due to limited awareness and access to regular checkups. So, the chart on the left-hand side shows the controls of all individuals with race and ethnicity. You can see that white Americans have the higher percentage of control, and the others are not so much. On the second chart on the right-hand side, it's showing basically low income households. It's showing high households all the way to very low, and all the way on the right hand side where it says hypertension, it shows how higher income households have a less percentage of hypertension. And then the very low income status, which is the dark blue, is showing the most percentage. So,
Okay, so when we are talking about the background of this project, we are talking about spreading the background of this presentation. We want to address the widespread and this preventable burden of high blood pressure, which is something that, as we've seen in previous slides, only in 2023, hypertension has been the primary contributor to almost 670,000 deaths in the United States only, and about only 60% of these adults that do have high blood pressure are aware of their condition, which where non-modifiable and modifiable risk factors contributes to the development of high blood pressure. And we as nurses, we do need to contribute to this population and educate them about the risk factors that they are probably they might present or not. For example, non-modifiable risk factors are things that the patients cannot get rid of. For example, their history of the family history, their age, especially men under 65 years old, they do have a more likely development of hypertension than women, but after 65 years old, both of them do have more chances of getting hypertension. And of course, race, since Black Americans, Hispanic, and Asian Americans have a higher risk of developing hypertension. And modifiable risk factors are those that they can change. For example, there's smoking, there's tobacco, there's stress, the obesity, the unhealthy diet, alcohol use, and their physical inactivity, which we as nurses, we can educate those patients to change their diet, to be more active, and of course, to reduce that the risk of getting hypertension. And hypertension is very important to is very important because it contributes to mortality of these patients. And when we are I brought a little bit of one North Bend, one of the school districts that we searched prior to this project. We learned that the healthcare access to this population has been decreasing, especially because four of the pharmacies in the area has closed down, especially the Rite Aids and the grocery stores that had pharmacies inside, which means the people that do have hypertension or other conditions that have medications, they cannot get to those medications because now pharmacies
Pharmacies
away from
away
them.
from them.
Right.
Right.
So when we are talking about also the increase of the population can increase the waiting times of getting appointments to the doctors for specialists, family practices, and especially emergencies. Over here with this chart, you can see I brought from Lansdale, which is one of the biggest cities in the school district that we looked into. You can see modifiable risk factors, which is the smoking in 15%, the physical inactivity of 21% of that population, sleep, which has been less than 7 hours, almost 40% of that population sleep less, and obesity at 31, almost 32 percent. And as you can see, high cholesterol and high blood pressure are very close together. High cholesterol is one of those that can increase the pressure on the vessels, which of course increase the blood pressure, and this is just like a cascade effect that you will have on those on that population of the people that do have the risk factors for um, hyperpressure. Okay, you can move. And what can we do as nurses students about this? Nurses are key for screening, for educating those patients, and for lifestyle modification support. So, giving those educations, giving those pamphlets about the DASH diets, the diets that are important for these populations to decrease the risk factors of getting hypertension or to control the hypertension. And also, we are a gap between the community care and the evidence-based care that we see in nursing school. We are talking about how we nurses need to know our community, what our surrounding, to be able to help those and find the risk factors and find what is missing in that community so we can help them reach well-being. That's it.
Okay, so I'm covering the assessment in this presentation, and you will see some of the information here are repeated again from the previous slides, and that's because the nursing process does not have like a 1, 2, 3, 4 to it. Something causes the other, or it's the result of something. So that's why you will see like maybe repeated numbers and some of the repeated information as well. As Jessica mentioned, so we have like half of the US adults are suffering from hypertension, and unfortunately only 24% of this population have it under control. And if we look at the causes for all of this, it will be, first of all, hypertension. A lot of people don't know they have hypertension because it's called the silent killer. It's gradual. So people, if they don't go to their follow-ups for so many reasons, we're just gonna cover in a little bit, whether they don't have access or they don't have like a health coverage, or maybe they just, they think they're healthy, as we have seen in this program when we covered definition of health. Everyone defines health differently. So people say, I'm healthy, I don't need to see a doctor. And unfortunately, when they go, it's too late, it's irreversible, it's there. And hypertension does affect the most important organs of the body, which is your cardiovascular system and your brain. Because when if you have like hypertension, which means you have like this consistent high pressure in your vessels trying to push the blood, so the ventricles are working harder, they enlarge, and that's how you get heart failure. And the same thing, they try to get through the pushes the blood into your arteries in your brain, and that's how people get stroke. It's serious, like MI, stroke. These are really serious and life-threatening events, all caused by hypertension, renal failure, vision loss, double vision. All of this is caused by hypertension. And so the rates are remained basically unchanged, unfortunately. And this is if we assess this, I think there's like a disconnect between conditions, education, access, and adherence. So if we give more education to these patients in community, like just like even like in fair events, a farmer's market, like anywhere, people will benefit from this. Because as I experienced during my clinical, I had patient who came in for the third time in 1 month for hypertension. When I was talking to him, and then he goes like, I cannot cook for myself, so I consume a lot of canned food, I consume this and this. I told him like, as something simple as teaching them how to read the label. So I was telling him, do you read labels? Now they have more options. Like for canned food, if you want to get like soup, you can look for no added salt. That's an option at the store. You can read it. And he goes like, oh, I didn't know. So really like simple things as reading label can prevent something serious as hypertension and AMIs and strokes. Um, Also, we have, as my classmates mentioned, we have African American population. We see like a high number with hypertension. Unfortunately, this has to do with the race. So people can, it's hard to control some of the factors, but something simple as diet or just keeping up with your doctor's visit can decrease the risk of getting hypertension. Also, as Jessica mentioned, low income families, because some of them, they cannot afford probably like fresh fruits and vegetables to offer meals every day. So they go for something cheap, for canned soup and canned food. Even unfortunately in food bank, they try to decrease poverty. We see a lot of what they offer is all canned food, and it's basically loaded with sodium, which is bad for our bodies. The limited care as well, and this has to be with social determinants of health. We have done so many research in communities since we started our nursing program about social determinants of health. And when we looked at our communities, we learned a lot, even though we have been living in here for so long, but we didn't pay attention that there is transportation problem, that people don't go to their doctor's visit. Poverty, as we mentioned, sometimes just like the knowledge, like there's no education. These are all preventative things. Just like if we have even to offer some flyers, a little bit of education will save lives. Next slide, please. Okay, so here we go again. If we assess, we go back to the same factors that are contributing to all of this. The new thing that I have in this slide is we look at the Americans, they consume about 3,400 milligrams sodium per day, which is pretty high compared to the recommended amount, which is 2,300 milligram a day. And also studies showed that low potassium recently impairs sodium excretion and increases blood pressure. So consuming a little bit more of potassium, decreasing sodium will help our community decreasing and preventing hypertension. And again, limited healthcare access, low health literacy impact blood pressure management, skipping and non-adherence, skipping meds and non-adherence. This is a big one as well. And sometimes they are just for our elderly population, sometimes they do skip their meds because they don't know like which one they took or when they take them. Sometimes they take one of their meds twice and forget to take the other one. And also with the adherence, sometimes the side effects, they hate the side effects of these medications. So some patients, they don't know, they can ask the doctor, can I have different medication? Like they don't communicate with their doctor, like, you know, the side effects are causing me this and this. Instead, they don't take the meds, and it keeps their hypertension elevated, which puts them on the risk for stroke or heart attack. These are just some numbers showing like hypertension diagnostic criteria according to the American Heart Association. So for stage 1 hypertension, we have 3 stages. Stage 1, which is systolic blood pressure between 130 and 139, or diastolic blood pressure between 80 and 89. Stage two, of course, the higher the number, the serious the stage is. And once we get to the third stage, it's irreversible and it can damage some of the organs of the body. So stage two, which is we're looking at the systolic blood pressure of 140, the systolic of 100, more than 120. And the last one is the crisis blood pressure systolic of 80 or above, or diastolic of 120 or above. And so reinforcing the need for localized nurse-led education and screening, schools, farmers market, as I mentioned, churches can really like save lives and help communities to live better and healthier. And this is going to lead us to our recommendations for our presentation.
Okay, so what I'm going to discuss is the top 3 recommendations. The first one being community-based teaching. As Maddie had mentioned, it's important to get into your community and identify demographics that may not be well informed about how to prevent comorbidities that are going to cause stroke and cardiac arrest and other diseases that can contribute to death. So we would do community-based teaching through screenings. It's obvious that a few of the demographics that are lacking mostly are the Black adult Americans and Hispanic communities, as well as Asian communities. And I think it's important that we start investing more time in providing screenings. That way we can instill trust that may have been lost at some point due to whatever that I might not be well informed about, but I think it's important to start there. Second recommendation is tech and reminders. So instilling education in patients with teach-back method on how to access their MyChart, how to access their lab results through Quest and LabCorp, and as well as be able to communicate openly with their providers and care teams. Third recommendation is health literacy education. So educating our communities on hypertension prevention in general through diet and exercise. An informed community can make better choices. Educating individuals creates better choices, and also performing or providing literature as well as recommendations to local providers so that they can make an informed decision on who they're going to pick to take charge of what needs to be done as far as their health is concerned. So community-based programs, health screenings, decrease systolic blood pressure by 20 points. Nursing role is to screen, educate, and follow up. So we want to ensure that these individuals are, after their screening, that we are providing the information to them so that they can pick a provider, choose the best diet, find a nutritionist, a dietitian. And our locations are carnivals, school fairs, First Fridays, farmers markets. We also have like the motorcycle shows and car shows where we can provide these, which typically has a higher demographic of males. And that is a population that is having a little bit more difficulty controlling their hypertensive crises. Evidence-based outcomes. So we just kind of repeated here. And moving on. This is a flyer that we could provide to our clients and individuals that we are going to be providing blood pressure screenings for. It's quick and simple. It's a evidence-based provider, American Heart Association, and it's reliable and trusted information. And we can give this information to a lot of people just by printing it out and handing it out. And it's pretty much just gives you the ranges that you want to be in, as well as the tips for success on how to maintain lower blood pressure and keep yourself healthy. So the recommendation 2 was tech and reminders. So basically, there's a huge population that does not have access to their personal health information. And as somebody who works in the healthcare community currently, I know a lot of people just don't know that they have hypertension. It's not mentioned. It's a part of our initial screening when a patient is brought back into a room. They may just not know what those numbers mean when we say your blood pressure is 148 over 94. They may think very well that's good. But if they were to just access their note and see that their doctor has diagnosed them with hypertension, maybe they would be more well informed to make better choices and better decisions. So, teaching somebody how to access their portal, access their information, I think is incredibly integral to prevention. So basically, what we would do, like I said, is the teach back method, teach them how to access their information, their test results, their medications, as well as communicating with their providers by creating messages. And then also how to access other portals for specialists, because not all of them are created equal. And then asking the patient to show us how they would access these as well, how to create a message to their providers, and how to access their lab results so they can see if their cholesterol is elevated, if their glucose is elevated, and maybe make better informed decisions and request calcium cardiac scoring based on their lipid profiles or hemoglobin A1C based on their elevated glucose test, which is all covered with insurance, but a lot of people just aren't aware of what that coverage entails. So, recommendation 3 is going to be health literacy education. I think where we start with a lot of patients is telling them to exercise and diet, and that's it. Like, lower your salt intake. And then when you tell a patient to lower their salt intake, they might start using salt replacement, which mostly includes potassium chloride, which can cause hyperkalemia. And then we have a whole different situation. So we want to make sure that we're informing patients on the appropriate dietary changes as well as the methods to access food and access better choices and teach them different exercise routines that can be modifiable to their bodies in particular. And then also monitor their blood pressure at home. I just spoke with a patient earlier that said she was paying $30 a month for a blood pressure cuff when she could have bought one for $20 on Amazon and not been charged such a quantity of money. And then basically just recommending things to patients so that they can make better informed decisions, like what should be ordered with their comprehensive physical exam annually that's covered. And that basically starts with a CMP, lipid profile, and a complete blood count. So this basically goes over the DASH dietary approaches to stop hypertension. It's modifying your current intake and trying to make it more accessible to all. So obviously, prices are going up, things are becoming less and less affordable. So we can recommend food pantries, but unfortunately, as Maddie said earlier, food pantries may not provide the healthiest options. Fruit spoils quickly, vegetables are cheaper in the can or in smaller quantities. So, recommending frozen vegetables and fruits to make smoothies and reheat in the microwave or in a pot of water may be a better option than the cans, which sometimes is the better price, but there's more quantity and it can keep longer in the freezer, and you can always reseal those items. Um, Trying to educate people on leaner meats, it's really difficult because a lot of people like their steak and pork. We are in the Northeast, so we have more access to beef and pork products. However, those are typically higher in sodium and higher in fat and do not have the vitamins and minerals that fish and poultry typically do. So it's important to make appropriate recommendations based on that. And then overall, recommending people reduce their sugar intake. This, however, leads to people consuming diet and non-fat products, which typically replace sugars and calories with other chemicals that mimic flavor and can cause an increase in other issues like increase in potassium or other chemical imbalances in our body. So we just want to make sure that when we're recommending modification, that we don't completely cut out the things people enjoy because the replacement might be less healthy than the original product. And then this is basically recommendation on exercise. So some of these are really realistic for a good population of individuals, but some of them aren't. Not everybody has access to a swimming pool. Not everybody can run or jog. Not everybody has a garden or a yard to work in. And not a lot of people like to listen to music, so they may not like dancing. So we're basically saying whatever is accessible to you, try to do more of. So if you do not live in a safe neighborhood or you do not work in a safe neighborhood, maybe brisk walking to elevate your heart rate is just not realistic. But what can you do at home? Can you use your kitchen counter to do push-ups? Can you use the wall of your apartment to do modified push-ups? Yes, great. Do you have an empty milk jug in your recycling bin that maybe you can rinse out and fill up with small quantities of water? There's your weight-bearing activity. Are you seated in a wheelchair or a chair because you only use a walker or a cane or a wheelchair? Great. That's another way we can modify your exercises is using resistant bands that are fairly cheap. And a lot of doctors' offices may have them stored away. Tying that around the chair of, or the leg of a chair and wrapping your ankle around it and doing extensions on your legs and your arms is one way to increase your heart rate and your breathing so that you are doing more aerobic activity to burn fat and burn those calories you're intaking throughout the day. So overall, these are recommendations for patients. We want to make sure that we're outreaching to our communities and seeing what needs they have instead of just educating. We want to make sure we're asking questions, we're assessing the situation, and then we know people's backgrounds. And if we don't know, we should ask instead of assuming. So something like this slide may seem absolutely ridiculous to somebody that can't run or walk or can't move at all. So we need to make sure that if we're trying to manage people's hypertension, that we're educated on the reason why they have hypertension to begin with. So I think that concludes our PowerPoint. Thank you for your time. And pause. Okay, now I just have to figure out how to, nope. How do we stop recording? Here we go.